Good morning and welcome to today's press briefing covering the Presidential Symposium abstracts that were presented earlier this morning. My name is Dr. Fiona Heggie-Johnson. Before I turn it over to the presenters, I'd like to say that this morning's abstracts were carefully selected from more than 1,800 abstracts which were submitted to this meeting, and those abstracts were scored and shared with our communications committee, which selected which abstracts would be presented at each of our daily press briefings. As is our custom, IASLC also includes one of our patient research advocates in each press briefing, and today's patient research advocate is Yvonne Diaz, who will provide a unique perspective on today's research. Please hold all of your questions until the end of the briefing. Let's get started. Our first presenter is on the FLAURA2 final overall survival data, which is presented this morning by Dr. David Planchard, a thoracic oncologist and head of the Thoracic Pathology Committee at Gustave Roussy, president of the International Center for Thoracic Cancers, CICT, a health cooperation group combining Gustave Roussy, the Marie Lanlong Hospital, and the Paris Saint-Joseph Hospital. Dr. Planchard, welcome to the press briefing.
So thank you to give me the opportunity to show again the result of the FLAURA2 trial, and particularly what we have presented this morning, the final overall survival on this population. I will just remind the design of the trial. So the design of the trial, which is a patient untreated, locally advanced or metastatic EGFR-mutated non-small cell lung cancer, histology to confirm squamous non-small cell lung cancer, and EGFR mutation, exon 19 deletion to L85R mutation according to local or central molecular testing, and the stable CNS metastases in the trial were allowed. Patients were randomized to receive either Osimertinib and pemetrexed, plus the choice of the investigator with carboplatin or cisplatin every 3 weeks up to 4 cycles, and it was followed by the maintenance treatment with Osimertinib and pemetrexed. In the control arm, patients received the standard of care in first line for this population, Osimertinib 80 milligrams once daily. The treatment beyond progression was permitted if patient derived clinical benefit as judged by the investigator, and the subsequent line of treatment was per investigator choice. We already have presented the primary endpoint, which was the progression-free survival according to the investigator assessment, and the overall survival was a key secondary endpoint. And so today we have presented the planning final overall survival analysis with 57% maturity. The baseline characteristic, I will not go deeper in detail, were well balanced between both arms. Just to notice, the most frequent EGFR mutation was exon 19 deletion, occurring in around 60% in both arms, and approximately 40% of patients had brain mets at baseline in both arms. At primary analysis, progression-free survival had been already presented in 2023, and the combination OC plus chemotherapy showed a statistically significant and clinically meaningful improvement in PFS versus Osimertinib monotherapy as a ratio of 0.62, and you can see the median PFS of the combination reached 25.5 months versus 16.7 months in the control arm, and the PFS benefit with the combination was consistent across all predefined subgroups, particularly patients with a worse prognostic, patients with brain metastases, and also patients with EGFR L85R mutation. So this is a patient disposition. In the FLAURA2 trial, 557 patients were randomized, 276 in the combination arm, 275 in the OC monotherapy arm. Just keep in mind that at the data cutoff, 28% of patients were still receiving Osimertinib in the combination arm, and 18% in the Osimertinib monotherapy arm, and 4% still receiving the chemotherapy maintenance with pemetrexed in the combination arm. Most frequent reason of discontinuation of Osimertinib in the trial and in both arms was progression disease, and the most frequent reason of discontinuation of pemetrexed were adverse events in the combination arm. So this is the most important data and the most important slide. the overall survival benefit in the combination. This is the red curves. So the median overall survival of patients who receive OC plus chemotherapy was significantly prolonged compared to patients that receive osimertinib monotherapy. Hazard ratio 0.77, p-value 0.02. Median overall survival of the combination reached 4 years, which is impactful for the patient, at 47.5 months compared to 37.6 months in the OC monotherapy arm. And the 3 years overall survival rate were 63% in the combination arm compared to 51% in the OC monotherapy arm. We looked at the subgroup population that it was previously presented with the progression-free survival. The overall survival benefit of the combination OC plus chemotherapy was consistent across all predefined subgroups, including patients with brain met and patients with EGFR-TKI mutation. Duration of exposure was prolonged with osimertinib. Median duration of exposure of osimertinib in the combination arm, I think it's quite unprecedented, 30.5 months compared to 21.2 months in the OC monotherapy arm. Median duration of exposure of pemetrexed, 8.3 months. So you can see the median duration of exposure of osimertinib was over 3 times longer than median duration exposure to maintenance pemetrexed. So meaning that many patients have a long period of chemotherapy-free, which is important, and why probably many patients receive a re-challenge with platinum-based chemotherapy in second line of treatment. And so this is what we have looked at. The first subsequent treatment, the majority of patients, when they relapse and stop the study drug treatment, they receive a subsequent line of treatment. And in the OC plus chemotherapy arm, 69% of patients who experience the disease progression receive a second line of treatment. And the most frequent second line of treatment were in 44% platinum-based chemotherapy and in 30% a non-platinum-based chemotherapy. And in the osimertinib monotherapy arm, 77% of patients who experience disease progression receive a second line of treatment, and the most frequent second line of treatment was platinum-based chemotherapy in 72%. So meaning in the control arm, the vast majority of patients receive standard of care with platinum-based chemotherapy at progression. Important things in terms of safety, no new safety signals were observed. Adverse event leading to discontinuation of osimertinib remain low, 12% in the combination arm compared to 7% in the OC monotherapy arm. And we do not observe any new treatment-related deaths with a combination of osimertinib plus chemotherapy. We know the most common adverse event, grade 3 or higher, mainly hematological toxicity in the combination, but mainly in the induction part when patients receive platinum-based chemotherapy, and same for the GI toxicity, mainly grade 1 and grade 2 toxicity. So with this additional follow-up, finally, no new issue have been observed in terms of safety result. So that's why we can conclude that the first line of OC plus chemotherapy demonstrates a statistically significant and clinically meaningful improvement in overall survival versus osimertinib monotherapy with hazard ratio 0.77. The median OS of the combination was 47.5 months, meaning 4 years median overall survival, which is nowadays the longest reported in a global phase 3 study showing OS benefit in this population. The OS benefit was observed across all specified subpopulations, and the combination OC plus chemotherapy at the long chemotherapy-free period, you have seen with a median duration of osimertinib exposure of 30.5 months, and in both arms, chemotherapy was the most common first subsequent treatment. Chemotherapy re-challenge mainly with platinum-based chemotherapy in the combination arm, and OC benefit with the overall survival benefit with the OC plus chemotherapy was seen despite the standard of care with platinum-based chemotherapy being the most common after OC monotherapy. And we do not observe any additional safety issue with the combination. So nowadays, this overall survival result from the FLORA2 trial confirmed that OC plus chemotherapy is the first-line standard of care in patients with an EGFR mutation, advanced non-small cell lung cancer with highly significant improvement in overall survival. And with this, I always want to thank the patient and the family, all the different study sites, and all the FLORA2 investigators and study members that permit to to lead this clinical trial. And with it, thanks for your attention.
So we're going to hold over questions to the end. So next, I'm happy to introduce Dr. Wang. She's going to present the data which was presented this morning by Professor Wang, and she is presenting data on Aumolertinib plus chemotherapy for non-small cell lung cancer with EGFR and concomitant tumor suppressor genes, the ACROSS-2 phase 3 study. Dr. Wang is a medical oncologist and clinical researcher specializing in thoracic cancers at the National Cancer Center, Cancer Hospital of the Chinese Academy of Medical Sciences in Beijing. Please welcome Dr. Wang.
Good morning. I'm glad to be here, and I'm on behalf of Professor Wang to report our phase 3 clinical study, the ACROSS-2, Aumolertinib plus chemotherapy for non-small cell lung cancer patients with EGFR and concomitant tumor suppressor gene. As we all know, EGFR mutation concomitant tumor suppressing gene patients had poor prognosis. Currently, we know the third generation EGFR-TKI combined with chemotherapy has showed that some patients may benefit from this combination. But we also know the increased adverse events in this combination. So how we should redefine the treatment of this kind of population? The ACROSS-2 study aimed to compare the efficacy and safety of Aumolertinib plus chemotherapy with Aumolertinib as first-line treatment in patients with EGFR sensitized mutation and cold tumor suppressing gene mutation. The study design, patients diagnosed with advanced or metastatic non-small cell lung cancer with NGS diagnosed with EGFR sensitized mutation and cold tumor suppressing gene mutation. Patients was a 1:1 ratio to randomize to Aumolertinib combined with pemetrexed carboplatin or Aumolertinib monotherapy treatment. The stratified factors included the EGFR mutation type and the same as metastasis. The primary endpoint of this study was the PFS per the investigators assessed. From October 2021 to September 2024, 126 patients across 26 sites in China were randomized. At last, 8 patients not received treatment. 118 patients randomized. The Aumolertinib combined with chemotherapy was 54 patients and 64 patients in the Aumolertinib monotherapy. At the data cut-off date, 8 August 2025, there were 37% patients in the combination treatment, ongoing treatment. There were 25% patients in the monotherapy group, ongoing treatment. This was the baseline characteristics. We can see the baseline characteristics between the two groups was balanced. About the primary endpoint, the progression-free survival, we can see with the median follow-up time of 25.3 months, the 63 events occurred. The primary endpoint PFS in the combination treatment was 19.8 months and 60.6 months in the Aumolertinib monotherapy group. We also did the subgroup analysis. We can see patients with cold TP53 mutations, we can see the combination treatment, Aumolertinib combined with chemotherapy, the PFS was 18.7 months, and the monotherapy group was 16.3 months. We also see patients with 19 deletion. We can see the combination group, the PFS was not mature. The monotherapy was 16.3 months. About the safety, we can see the TEAE in the combination group was relatively high compared with the monotherapy, but the common TEAs was grade 1 to 2. The common TEAE were hematologic toxicity, mainly included anemia, white blood cell decreased, and the ASTLC increased. This study shows us Aumolertinib combined with chemotherapy has a significant clinical improvement in the PFS. We can see in the combined treatment, the median PFS was 19.8 months. Compared to the monotherapy, the median PFS was 16.5 months. Most adverse events was grade 1 to 2. The addition of chemotherapy did not alter the safety profile of the Aumolertinib monotherapy, and no new safety signals were observed. Thank you for all our patients and their relatives, and thank you for all our investigators. Thank you.
Thank you very much, Dr. Wang. Our third presentation comes from Dr. Jonathan Goldman of UCLA in California. Dr. Goldman is an associate professor at UCLA, California in the United States, where he performs clinical research to improve the care of lung cancer and other solid malignancies. And this morning, he will present data from the HARMONi study on Ivonescimab versus placebo, plus chemo, a phase 3 study in patients with EGFR mutated non-small cell lung cancer progressing with third-generation EGFR-TKI treatment.
Thank you. I finally updated my profile. I've achieved full professor a little while ago. No, I realized it was not updated for a little while. Thank you very much. It's my pleasure on behalf of my co-authors to present our data from the phase 3 HARMONi trial of Ivonescimab versus placebo in combination with chemotherapy for EGFR mutated non-small cell lung cancer after an EGFR-TKI. Ivonescimab is a bispecific antibody to PD-1 and VEGF. The trial enrolled patients with locally advanced or metastatic non-small cell lung cancer with an EGFR sensitizing mutation that had progressed on a third-generation EGFR-TKI, ECOG performance status of 0 or 1, and any PD-L1 expression. Randomization was 1-to-1 and stratified by the presence of brain metastases. Enrolled subjects received Ivonescimab at 20 milligrams per kilogram or placebo in combination with a backbone chemotherapy, carboplatin and pemetrexed every 3 weeks. Co-primary endpoints were overall survival and progression-free survival by independent radiology review. The trial began as a trial in China, and that HARMONi A trial has been previously reported. The trial was then expanded to North America and Europe. The specific accrual timelines are listed on the right. The two arms were well balanced by all demographic factors: age, gender, region, race, ECOG status. 25% had brain metastases. All had received a prior EGFR third-generation TKI, either in the first line or after an earlier generation agent. 62% were from Asia and 38% were from the Western population. About 60% had exon 19 deletions, 35% L858R, and 5% had non-canonical mutations. The trial met its PFS primary endpoint with a hazard ratio of 0.52, a p-value less than 0.0001, and at the medians, 6.8 versus 4.4 months. There was approximately 20% patients that continued to be progression-free, 20 more percent that were continued to be progression-free at the 6 and 12-month landmarks. The PFS forest plot shows benefit across all predefined subgroups, perhaps more benefit in those with brain metastases. In that group, the hazard ratio is 0.34. This slide shows the consistency of data. The solid line is the primary PFS analysis. This was event-driven and occurred prior to total enrollment of the trial. The dotted line is after the completion of enrollment, including all of the Western patients and with additional follow-up. Looking by region, the Asian subgroup had a hazard ratio of 0.55, and the Western population 0.67. Only the Western population were required to submit PD-L1 levels. So among 160 subjects, there did not appear to be a significant difference in benefit based on the presence or absence of PD-L1. This is the overall survival curve. There's a difference at the median of 16.8 versus 14.0 months, hazard ratio of 0.79, and a p-value of 0.057. Slides were, there was an updated slide there with an updated follow-up analysis with additional follow-up. But moving on to objective response rate and disease control rate, 11% absolute increase in the Ivonescimab arm. Duration of response was improved from 4.2 to 7.6 months. Treatment-related adverse events were similar in the two arms, looking at grade 3 and above, 50% in the Ivonescimab arm and 42% in the placebo arm. Because this drug is dual-targeted to VEGF and PD-1, we split up the adverse events by immune-related and VEGF-related. In the next slide, we'll show some more detail. The events by term are listed on the right. Most are lab abnormalities, nausea, and decreased appetite, consistent with the chemotherapy backbone, and thus were not different or minimally different between the two arms. Immune-related adverse events on the left were primarily low-grade. Thyroid abnormalities were the most common. The other events were at low rates and low grade. The pneumonitis rates can be called out as low rates, and grade 3 plus pneumonitis was, I think, 1.4% in both arms. VEGF-related events on the right, proteinuria, hypertension, and hemorrhage, but mostly low grade. Serious hemorrhage was in less than 1%, and similar events of venous and arterial thromboembolism in the two arms. So in summary, Ivonescimab had a significant and clinically meaningful progression-free survival benefit, hazard ratio of 0.52, and consistency across the subgroups, particularly of note in the brain metastasis present group. Overall survival improvement trend, and improved response rate and disease and duration of response. Of note, the drug was well tolerated with low serious events of bleeding and overall. Additional follow-up has been analyzed and has been reported. Thank you very much.
Thank you, Dr. Goldman. And next up, we have a presentation on the pivotal AROS-1 study by Dr. Alexander Drilon of Memorial Sloan Kettering in New York. Dr. Drilon is the Chief of Early Drug Development Service and attending physician of the Thoracic Oncology Service at Memorial, and his research focuses on the development of targeted therapies for genomic subsets of lung cancer and other solid tumors, including cancers that harbor fusions involving ALK, ROS1, RET, NTRK, and MET exon 14 skipping alterations. And Dr. Drilon, it's great to have you at the WCLC press briefing. Thank you.
Thank you very much to IASLC for featuring this work. Today we're going to talk about a new ROS1 inhibitor for patients whose lung cancers harbor the ROS1 target, or what we say ROS1 positive lung cancers. So we're very fortunate to have really talented chemists that are able to design new oral therapies or pills that can work after older pills have stopped working. And because they might be better than these older pills, the thought is to move them up to first-line therapy, where someone who's never had a pill for their cancer might take that new pill for the first time and hopefully have good outcomes. And that gets to the design goals of this new ROS1 pill that you see on the left. That's very selective for the ROS1 target. It was also designed by the chemist to target resistance to these older pills, really penetrate the brain well, knowing that many patients with ROS1 positive lung cancers can have their cancer go to the brain. But also it was uniquely designed to avoid side effects that some older pills had that were mediated by hitting a target that was not ROS1, in this case TRK. So what is this study? It's the ARROS-1 study. It was a global study, phase 1/2, so an early phase clinical trial that treated patients actually with any cancer that had a ROS1 target or a ROS1 fusion. But today we're specifically going to talk about ROS1 positive lung cancers. And if you'll focus your attention on the middle, you'll see that we have selected the dose for this drug already. It's 100 milligrams daily, so easy once daily dosing. And you'll see that patients were treated that had never had a ROS1 pill before or had one or more prior ROS1 pills. And that's with or without chemotherapy. Now, if you focus on the right of the slide, you'll see that as of March of this year, 514 patients with any ROS1 positive cancer were enrolled. We pulled out only the lung cancer patients, and there were 432 of them that got this chosen dose of 100 milligrams daily. And if you look below that, the activity population, how well this drug worked in patients who had had a prior ROS1 pill, we're going to talk about that in 117 patients where we were able to measure this activity. Finally, for the very first time, we're also, as I mentioned earlier, trying to push these new pills up to the first pill that lung cancer patients take. And you'll see on the lower right that we're going to feature preliminary data in patients who have never had a ROS1 pill and see how they do. So here we have a summary of the characteristics of the ROS1 positive lung cancers who had received a prior ROS1 pill. And I'll simplify this and say that the profile that you see here is typical for what we see for ROS1 positive lung cancer, so not a surprise. Talking about the brain, which we mentioned earlier, almost half of patients did unfortunately have their cancer go to the brain. There was also resistance that we talked about in the design earlier that manifested as these ROS1 mutations that occurred in more than a third of patients, with a special and one of the most common ones called G2032R in north of 20% of cases. A little over half of patients also had chemo, and that was typically a platinum drug and pemetrexed. And then, as you'll see on the right, about half of the patients had one prior ROS1 pill, either crizotinib or entrectinib, and the rest had two or more, sometimes up to 4 prior pills. And that group included some of the more recently approved ROS1 pills, like repotrectinib, which was approved last year, and taletrectinib that was approved a few months ago. Now here we have the activity again in those patients who had received a prior ROS1 pill. And if you focus on the table above, you'll see that in patients that had had any prior number of ROS1 pills, up to 4 total ROS1, TKIs we call them, the objective response rate was almost 45%. That was the number of patients that had really good shrinkage with this therapy. If you only pull out patients that had one prior pill, either crizotinib or entrectinib, the objective response rate was approximately 50%. And you see in this nice plot below, which shows you how much these cancers shrank in the areas that we were able to measure. You see that most patients actually had their cancer shrink to various degrees, but there are certainly some cancers that shrank very dramatically and disappeared in terms of the areas we were able to measure with a ruler on these scans. Now, on the upper right, interesting data we have here in patients who have had 2 or more prior pills. And I mentioned that the most recently approved ROS1 pills are repotrectinib and taletrectinib. So it's important to know if this new drug works after those pills. And in fact, even though numbers are smaller, because these are more recently approved drugs, we do see this agent work in almost 50% of cases with patients who have received repotrectinib, and north of 40% of cases in patients who have received taletrectinib that was approved a few months ago. So very encouraging that you can start with an older pill and then hop onto this new pill and have a good response with treatment. Now, how long do these responses occur? That's summarized in this slide, where you have 2 metrics, the duration of response, we say, on the left, and the progression-free survival on the right. And I'm just going to summarize and say that the median duration of response and progression-free survival in patients who had any prior number of ROS1 pills was 22 months, so under 2 years, and 9.7 months, or approximately 10 months, respectively. And if you pull out patients who only had 1 prior ROS1 pill, the median duration of response, again, is 22 months, but now the median progression-free survival is almost 2 years at 23.8 months. So encouraging that someone's cancer can shrink well on this, but also the cancer can stay under control for a very long time. Finally, we mentioned in the design principles that the drug was designed to get into the brain and also cover resistance, and we're certainly seeing that in the tables here, where you see, I'll just focus on the patients that had 1 prior ROS1 pill. The objective response rate is greater than 80% in the presence of that most common mutation, the G2032R. And then in the brain on the right, you see that in patients who have had 1 prior pill, crizotinib, the objective response rate in the brain specifically, measuring only the brain metastases, is 85%. Now, the last question everyone wants to know is whether or not this new pill is something that's tolerated well. And you'll recall that in the first slide, we said that the chemist had designed this to try to make it much more tolerable than prior pills. And we're certainly seeing that here in this summary of the side effects of the drug, where you'll see that the most common side effects were some swelling in the legs in many cases, constipation, an increase in one of the muscle numbers, even though patients generally didn't feel that, some tiredness and some shortness of breath. And on the right, you'll see that actually there was a low number of patients that had to have their dose tweaked. So only 1 out of 10 needed their dose reduced for a side effect, which is encouraging because many other pills have a higher frequency. And then only 2 out of 100 patients had to stop the drug because of a side effect seen on the trial. So in summary, I think this highlights that certainly we're very excited about this new pill. What we've seen in the chemistry, the design of it has really translated into these data that we've seen both in terms of how active it is and how much more tolerable it can be compared to older pills. And we look forward to hopefully seeing this approved by the FDA and other countries. Thank you.
And our final researcher is Dr. David Gerber from the University of Texas Southwestern Medical Center, who'll present data from the phase 3 trial of crizotinib versus observation for surgically resected early-stage ALK and ALK-positive non-small cell therapy. Dr. Gerber is a thoracic medical oncologist at the UT Southwestern Harold Simmons Comprehensive Cancer Center in Dallas, and his research encompasses biomarker, clinical, and epidemiological studies of lung cancer. And thanks for joining us, Dr. Gerber.
Thank you for the invitation. Okay, so I'm going to be speaking today about the ECOG-ACRIN E4512 phase 3 trial of crizotinib versus observation for surgically resected early-stage ALK-positive non-small cell lung cancer. By way of background, you'll see that there are an awful lot of authors listed for a trial that ultimately wasn't very large. This trial required extensive multidisciplinary, multi-institutional collaboration throughout the United States, and I'm very thankful for this support. So before we talk about the E4512 trial, I just want to remind everyone about the Alchemist screen platform. So Alchemist stands for Adjuvant Lung Cancer Enrichment Marker Identification and Sequencing Trials. It is sponsored by the United States National Cancer Institute, and what Alchemist has been doing for more than the past 10 years is enrolling patients with surgically resected early-stage non-small cell lung cancer using the current staging system that correlates to stage 2A through 3B. And Alchemist collects clinical and molecular data on those cases, and then depending on tumor characteristics, patients enrolled in Alchemist may be offered adjuvant or post-operative therapeutic oncology trials depending on the tumor characteristics. So one example of those studies, and that I'm talking about today, is E4512 for cases that are ALK positive. So today you've heard about ROS1 positive cases. You've heard about EGFR mutant cases. This is another subset of lung cancer. In metastatic lung cancer, we usually think of ALK positive cases as probably around 3 to 5%, and we have learned that it might be even less common in surgically resected cases. So to be enrolled in the Alchemist, in E4512, patients would have been enrolled in the Alchemist screen protocol. For surgery, they had to have negative surgical margins, so the surgeon had to get all the cancer out. The testing, the biomarker testing for the presence of the ALK alteration could be based on local test results only, or it could be based on the central test result that was done as part of this study. It's common for patients after surgery for lung cancer to receive chemotherapy and sometimes radiation, depending on the stage of lung cancer. And in this trial, both of those were allowed before going on the E4512 trial, but they were not required. For the patients who did go on the E4512 trial, you'll see on the right side that they were randomized to either 2 years of an ALK inhibitor called crizotinib or 2 years of observation. Early on, this study randomized people to placebo instead of observation, but when we realized how rare ALK-positive lung cancer was in early-stage disease, we did everything we could to enhance enrollment, and one of those things was removing the placebo arm. The primary endpoint of this trial was disease-free survival. So for people who've had surgery for lung cancer, that's really how long until lung cancer is found to have recurred. Secondary endpoints were overall survival and toxicity. When we randomized the patients, we stratified, so made sure there was balance according to the stage of the lung cancer, the sex of the patient, male versus female, and whether or not they had prior radiation. Now, although someone could be enrolled in E4512 just based on the local ALK testing that had been done in their hospital, when we looked at the primary endpoint of disease-free survival, it was only analyzed in cases where the central testing that we did was positive. So this trial, E4512, was activated in August 2014, almost 10 years ago, or more than 10 years ago. That was when the Alchemist screen protocol, the overall platform, was activated. About 10 years after the trial was activated, enrollment was stopped. It was stopped at the time that the United States Food and Drug Administration approved adjuvant or postoperative alectinib, another more recent, more effective ALK inhibitor, was approved for resected ALK-positive non-small cell lung cancer. So when the trial E4512 was stopped, we had almost reached our target enrollment of 168 patients. We had enrolled 166 of them. Because ALK-positive lung cancer is so rare in early-stage disease, those 166 patients were enrolled from 84 participating medical centers. You'll also see that those 166 patients represent only about 2% of the 7,345 patients that had been enrolled to Alchemist Screen. Of the 166 patients that were enrolled to E4512, 93% of them, or 154, shown at the bottom of the slide, were centrally ALK positive and were included in our efficacy analysis. The trial was stopped in April 2025 after recommendations of the Data and Safety Monitoring Committee. So in terms of patient characteristics, I've divided this table into kind of the left columns and the right columns. About 2/3 of the patients were women. About 80% of them were non-Hispanic white, and fewer than 10% of them were Asian. And that's important because a lot of the other trials looking at ALK inhibitors in lung cancer, including early stage disease, enrolled a large proportion of Asian individuals. About 2/3 of our patients had never smoked. They were lifetime never smokers, and that's typical, not only for ALK-positive cases, but also the other subsets of lung cancer you've heard about today, like ROS1 positive and EGFR mutant. More cases, shown on the top of the right side of the slide, were stage 3 than stage 2. And the missing stage designation here just refers to the fact that we noticed discordance between the initially recorded stage and the stratification grouping, and that's being reviewed currently. I mentioned before that we did not specify what type of surgery had to be done for patients to be enrolled on this trial, but we saw that about 3/4 or even more had at least a lobectomy, so one lobe of the lung removed. Some of them also had pneumonectomy, or the complete removal of a lung. Lymph node assessment was relatively complete in about 70% of cases. Although we didn't require it, 90% of patients enrolled on the trial had received adjuvant chemotherapy before being randomized in the study, and about 1/3 had received postoperative radiation. So in terms of our primary endpoint of disease-free survival, on the left you'll see that there's no difference between crizotinib and observation. Our hazard ratio is 1.06 and our p-value is 0.86. And this was looked at after a median follow-up of almost 5 years. We also looked at disease-free survival in subgroups according to the cancer stage, the patient's sex, and whether or not they'd received postoperative radiation. And there's no difference in those groups either. On the right side, the first thing you'll notice is that we would say that these data are not very mature for looking at overall survival, and I think that's a good thing, right? After 5 years of follow-up, the vast majority of patients in both arms are still alive, and so it's too early to make any conclusions about overall survival in this study. This clinical trial, in terms of collecting toxicity data, focused on higher grade toxicities that were thought to be treatment related, specifically grade 3 and grade 4 events, and those occurred in 43% of patients receiving the crizotinib ALK inhibitor. Only one of those cases was actually a grade 4 event, and it was a stroke. These toxicities that we see in this trial look an awful lot like the toxicities we've seen before from crizotinib in earlier trials, usually in metastatic lung cancer. The most common ones we saw were diarrhea, edema or swelling, eye disorders, which is a very interesting temporary change in people's vision where they may see flashers, they may see shadows, but that almost always improves spontaneously, even if you continue dosing. Abdominal pain, increase in liver chemistries, and decrease in blood counts. The median duration of crizotinib was a little over 13 months, and 40% of the patients that we enrolled to this trial completed all 2 years of crizotinib. but 27% of the patients who started crizotinib stopped it before the 2 years because of a toxicity. So in conclusion, when you step back and think about our overall Alchemist screen population that enrolled almost 7,400 patients to get us to this point of our E4512 ALK trial, in that overall population, only about 2% of cases were ALK positive and enrolled in this specific trial. If local ALK testing was performed at the patient's hospital where they had their surgery done, and it was compared to the central ALK test result, they agreed over 90% of the time. And that's important for us to know, so we know that we can rely on these types of biomarker testings done in different healthcare institutions. Adjuvant or postoperative crizotinib did not prolong disease-free survival compared to observation in surgically resected ALK-positive non-small cell lung cancer. I mentioned before that we didn't see a difference in overall survival either, but that data is not mature. And the toxicities of crizotinib resembled those that we've seen before in clinical trials in metastatic ALK-positive lung cancer, and it led to people discontinuing their treatment in more than a quarter of cases. That's everything. Thank you.
As I stated at the beginning, IASLC always includes a patient research advocate in our press briefings, and today we are very fortunate to be joined by Yvonne Diaz, a co-founder and the chair of the Oncology Cancer Research, a UK-based charity focusing on advocacy and funding research for oncogene-driven lung cancers. She is also a board member of the US-based ALK Positive Inc. and a member of Lung Cancer Europe, and please welcome Yvonne.
Thank you, everyone. It's a pleasure to be with you as someone living with lung cancer, involved in research advocacy, seeing today's presentations. I'm seeing today's presentations through the eyes of people living with lung cancer and also their families. Every new trial, every new incremental step forward means more time, more hope, and options for real people. So thank you for all you do. Today, obviously, we had 3 EGFR abstracts, FLAURA2, ACROSS, and HARMONi. And what's striking in the EGFR studies is a commitment to keep pushing the boundaries, whether it's around extending survival in the first-line setting, with combinations, finding new ways to treat harder to treat EGFR disease, and also addressing what happens next, because we're also always thinking ahead to what's plan B and C. For patients, this very much reflects the life we live every single day, the need for the best possible start and the ability to continue. So I'm going to reflect briefly on the presentations for Dr. Blanchard's excellent presentation on FLAURA2. I would add that for us, staying on our first-line targeted therapy is key. It's impressive to see the survival advantages that are achieved by this combination. The consideration from a patient point of view is living with ongoing chemo is a big change in our daily lives, right? In quality of life, it requires more time in hospitals, being more medicalized. This patient population is often younger, in their work prime years, raising our families. So it's important to think about this, right? So we think about how do we decide who is the best patient population for a combination like this? What kinds of supportive care can be placed around the patient? Because at the end of the day, we do also want to live longer. We want to take our treatments. Patients in the first-line setting are quite vulnerable. So understanding a very complicated new treatment is difficult for us. So how do we participate in shared decision-making? How do we participate in informed consent? And how do we take it all in? I think these are things that will be going through our minds and where we need some support. for Dr. Wang's presentation this morning on the ACROSS trial. It's really great to see also addressing a tough reality that not all EGFR lung cancers behave the same way. Some of us have these co-occurring mutations, making our cancers harder to treat, and obviously the outcomes worse, which is really painful to see in our community. Again, combination strategies, adding chemo, they may not be easy, as we've already also, I just said on Flora too, but they do give more time and more options. So for us, it's encouraging to see this cohort being studied, this more challenging cohort, and the adverse events from what were reported appear manageable. A key question for us will be, how long is long enough on the chemo option as well? So on HARMONi, Professor Goldman, your presentation today, for anyone hearing the words that your treatment stopped working is the most shattering thing. It takes us back to those early days, and it can often feel like we are falling off a cliff. So seeing trials like HARMONi studying what do we do next is really bringing so much hope to our community, and it's something we want to see solved. In the main session, obviously, we also heard Dr. Ramalingan's presentation as a discussant, and I do think it's important for us to understand why is there such a better response in the Asian population than what we saw today. Is there anything we can take away from that from people of Asian descent living elsewhere in other populations? Is there anything different? It's also important for us to have more second-line options after osimertinib. This is complicated for clinicians. It's even more complicated for patients who are extremely vulnerable. We're under extreme stress at these times when things are going wrong. And again, trying to make this informed decision is not an easy thing for us. So anything that can support us through this very complicated time is going to be of importance. For ALK, and Dr. Gerber, it's encouraging to see early stage trials being attempted when the chance of a cure is greatest. So we do like seeing that. It's not easy, as you said, to find these ALK patients, but it's very important to us. I do also find it encouraging that while the adjuvant crizotinib trial was disappointing, closing it shows a respect for patients as well, because our safety, our time, and the trust we are placing in research is also really important to us. The trial clearly asked the right questions, even if the drug wasn't necessarily the right match. But it was a very important trial, so thank you. For our ROS1 community, ROS1 lung cancer we know is rare, and this patient population can also often feel very invisible in the broader lung cancer conversation. So having a pivotal trial like this shows this group that they do matter, and the science is also working for them. So very, very exciting. We do like seeing that it's also looking at all ROS1 disease from the first line setting all the way through those that are heavily treated, which is a reality in our community. The brain activity is also significant for us because we know that brain mets are a reality. They affect survival, and in some cases also quality of life. It's always a concern when people are hearing it's going to your brain or it's gone to your brain. The track sparing, I have to say, is something that we do discuss in the patient community because of all the side effects that do happen. So anything to reduce that, the neurological side effects, the weight changes, which again, we want to return to a normal life where that is possible. That's also important to us. With the Zida potentially coming into the first line setting, again, we need careful guidance. How do we participate in this shared decision making? There's so many options, which is a good thing, right? It's hard for clinicians, it's gonna be hard for us. And now seeing that in the first line setting, we're always thinking, what does plan B look like? So obviously this is just being studied now. That may not be understood, but those are questions we are going to be looking for. For those that have been heavily pretreated, it's important to know that there is one more option, and it's a targeted therapy. That is always a blessing to know there's another targeted therapy in the armory. So very exciting. In closing, I would say the common thread across these presentations is that progress comes not from a single breakthrough, but from a pipeline of innovation, right? More combinations, more next-line options, newer targeted therapies. For patients and families, we also see that there's no one-size-fits-all treatment here. So it's important to see these continued studies and also to try and then, as been highlighted a couple times already, who is best for each approach. And we patients want to see this momentum continue, but it must be it must translate into real access for patients everywhere, because innovation only matters when it can reach the patient. So thank you so much.
Thank you so much for sharing those unique and important remarks, Yvonne. I'd like to thank all of you for attending the press meeting, including those who accessed the briefing online, as well as those who will review the briefing on our YouTube channel. And we'd be happy to take any questions. Yes, you start first.
My name is Isao Yokoyama of Nikkei Cancer, and I'm a Japanese journalist. I'd like to ask Dr. Planchard, in FLORA sub-analysis, Chinese has always benefit, but non-Chinese AGM doesn't have no OS benefit. How do you think about the difference?
Thank you for the question. I would be cautious about the subgroup analysis. You know, it's only exploratory, and the trial is not enough powered to make any statistical analysis subgroup by subgroup. And what have been seen in the subgroup, and you have seen the 95 confidence interval, they're all superposable. And so that means nowadays we cannot conclude that there is a group who have a better prognostic of the combination than another one. So you have to be cautious by this. And even in this Asian non-Chinese population, you have seen the lower bound, they cross the hazard ratio value of the overall population. So that means it's consistent to say that the combination have a benefit, whatever the subgroup population. So be cautious about this. On the other side, it was subgroup on the overall survival, so it can take in account the further line of treatment, and probably in some population, patients do not have the same access in second, third line of treatment. And when you look at the PFS, which really evaluated the benefit of the combination, in this case, there is no doubts. Whatever the subgroup population, you have a benefit of OC and chemotherapy.
Thank you very much.
Thank you.
Hi, this is Minghua Lu from eChina Health. I have a question for Dr. Wang. How about the CNS as a stratifying factor? Did the combination treatment improve survival in patients in this group?
Thank you for the question. For the brain metastasis group, we didn't show the data because the data was immature, but we had seen the trend, the combination treatment compared with monotherapy, the improved progression-free survival, and we will read out this data later when it mature. Thank you for your question.
So if there are no further questions, I think we'll close the session here. Thank you.